This is an explanation of how to use maintaining a safe environment assessment and care plan within the document. So we look at the nursing assessment first. The patient's mental state, are they alert, confused, restless, altered level of consciousness, low mood or depression? So you tick whichever apply. And then here, if the patient is confused, restless, altered level of consciousness, low mood or depression, or over the age of 65, complete the 4AT assessment on page 8. So I'll just scroll down to page 8. This is the 4AT assessment test for delirium and cognitive impairment. Complete on admission on all patients over 65 and refer to the delirium in general hospital algorithm. So the first part of this, we look at the patient's alertness. So this includes patients who may be markedly drowsy, for example, difficult to rouse and or obviously sleeping during assessment, or agitated or hyperactive. Observe the patient. If asleep, attempt to wake with speech or gentle touch on shoulder. Ask the patient to state their name and address to assist rating. So if the patient has normal alertness, which means they're fully alert but not agitated throughout the assessment, we give the patient a score of 0. So we put our score in the box here, okay? We document our date here and our score here. If the patient has mild sleepiness for less than 10 seconds after waking, then normal, we score 0. If the patient has clearly abnormal alertness, then we score 4. So we go down to the second section, AMT4. So we ask the patient their age, date of birth, place, which is the name of the hospital or building, and the current year. So if they give no mistakes, a score of 0. If they have one mistake, a score of 1. 2 or more mistakes, or if they're untestable, a score of 2. The next section is attention. Ask the patient, please tell me the months of the year in backwards order, starting at December. So to assist the initial understanding, one prompt of what is the month before December is permitted. So for the months of the year backwards, if the patient achieves 7 months or more correctly, they get a score of 0. If they start, but if they score less than 7 months or refuse to start, a score of 1. If they're untestable, they cannot start because they're unwell, drowsy or inattentive, a score of 2. So part 4 then is acute change or fluctuating course. So if there has been evidence of significant change or fluctuation in alertness, cognition, other mental function, for example paranoia, hallucinations arising over the last 2 weeks and still evident in the last 24 hours. So if no, a score of 0, and if yes, a score of 1. So you add up all your scores here to get your total 4AT score. You put in your initials here, and then below we have the score guidance, okay? So if the patient scores 4 or above, that indicates that the patient has possible delirium plus or minus cognitive impairment. So suggest delirium, inform medical team, repeat tests daily for 7 days. Cease testing if delirium is diagnosed and commence care plan 1B. Okay, and we'll go back to 1B in a minute. Score of 1 to 3, possible cognitive impairment. Inform the medical team or the care of the older person, ANP, CNS, if the patient is over 65. Repeat tests daily for 7 days. Cease testing if delirium diagnosed and commence care plan 1B. Also provide information leaflet on delirium to patient or families or carers. And if the patient scores a 0, delirium or severe cognitive impairment is unlikely. However, delirium is still possible if section 4 information is incomplete. Repeat the test tomorrow. Okay, so we go back up to our assessment. Okay, so if the patient has been diagnosed with dementia, delirium, depression or cognitive impairment, we activate this care plan here, 1B, we tick the box here, and then we activate the interventions that are relevant for that patient. We go back to our assessment here. Does the patient have an ID band in situ? Tick yes or no. Have they been orientated to the ward layout? Yes or no. Have you fallen within the last year? Yes or no. So if the patient has fallen within the last year, describe how the patient fell. And does the patient require any safety measures that can be documented there? Has the patient a fear of falling? Yes or no. Any other risk factors that might increase the patient's risk of falling? Yes or no. And you can specify there. If yes to any of the above, complete the falls risk assessment on page 7. Also, the falls risk assessment tool, Stratify, must be completed on all patients over the age of 65 on page 7. Okay, so I'm going to scroll down to page 7. And this is the Stratify falls assessment tool. So this needs to be completed on admission and then weekly or as indicated. Circle no for 0 and yes for 1. Okay, so we put in our date at the top and the time, and we go through each element here. So 1 is the patient in hospital as a result of a fall, or has he or she fallen since admission? So you circle 0 or 1. Do you think the patient is agitated? Does the patient have any visual difficulties that affect everyday lifestyle? Does the patient need to visit the toilet more often than every 4 hours? Can the patient mobilise independently and safely with or without a walking aid? And is the patient an inpatient with drug or alcohol related problems? So you add up all your scores to get your total score, and you put in your initial here. Okay, so if you come over here, a total score of 2 or more indicates that a care plan is required. So it indicates that the patient is at high risk of falling. However, a care plan may be required with a score of less than 2. Use your professional judgment. So even if your patient isn't scoring on this and you still feel that the patient is at risk of falls, you can still activate a care plan. So when you're activating the care plan 1C on page 6 for person at risk of falls activated, yes, you tick there. Okay. So if a patient does have a fall, there is a list of post-fall care interventions. Okay. So 1, check for injury. 2, safe manual handling. 3, neurowabs. 4, medical review. 5, document interventions carried out in nursing evaluation notes. 6, reassess falls risk. 7, review care plan. And 8, inform next of kin where appropriate. Also, please record all falls or near falls on Q-Pulse, and also record the date and time of all falls and reassess falls risk and care plan. So here you can record the date and time of all falls that have occurred. Okay, so it's just so you can see at a glance if your patient, if they've had falls, how many falls they've had, what time of day have the falls been happening at, is there a pattern that we can see. So it's just that the nurse can see that at a glance rather than having to log into Q-Pulse and finding out that information. So I will scroll back up to this page here. So again, it's this care plan here, 1C, risk for falls. So we tick this box and we activate whichever interventions that we will be applying for this patient. So for example, patients located in an observable ward area, we may activate that. Apply orange falls wristband, we'd activate that. Ensure patient wears well-fitted clothing and non-slip footwear. Review mobility aids and place within reach of patient. Nursed on ultra-low bed if necessary. Check lying and standing blood pressure on admission or as directed or as necessary. Provide patient with falls leaflet. Liaise with the physiotherapist, OT or social worker. Liaise with the pharmacist or medical or psychiatric team for medications review and monitor for side effects. Okay. Involve family in care as appropriate. Ensure optimal position of invasive devices of all times. Carry out neurological observations, refer patient to the care of the older person AMP. They may all be relevant for your patient. So you go through each one of them and you activate whichever is relevant for your individual patient. The other thing we need to look at is whether we should be using bed rails on this patient or not. So if you are considering the use of bed rails, you're after assessing the patient, you've discovered that they're high risk of falling, maybe the patient is very frail, very elderly, and you think that the patient may benefit with the use of bed rails. Well, we need to do a risk balance assessment before we make that decision, and that is on page 9. So I'll scroll down to page 9 of the document. So this is the risk balance tool for bed rails, and this should be used in conjunction with your clinical judgment. So detailed risk balance tools are good at conveying the need to balance an individual patient's multiple risk factors. They also reflect the legal requirement that decisions are made in the patient's best interests when they lack capacity to make their own decisions. However, they rely on staff having a realistic picture of relative risks. So the idea is you give a score of 1 for each risk identified and add up the total score at the end. So the green side looks at the risk of not using bed rails, and then the red side looks at the risk of using bed rails. Okay, so I suppose the issue with bed rails is that they may pose of more of a danger to the patient than not using bed rails. Some patients may be very confused and agitated and may attempt to climb out over the bed rail and end up causing greater injury to themselves than if they had just fallen directly out of the bed, for example. Okay, so we need to show that we have assessed this before we've made our decision. So we look at the risk of not using bed rails first. So you put in your date and it asks you a question: how likely is it that the patient will fall out of bed? Patients may be more likely to slip, roll, slide or fall out of bed if they, okay? So for each one of these that apply, you put a score of 1 in the box, okay? So if the patient has fallen from bed before, have been assessed as having a high risk of falling, if they're very overweight, if they are semi-conscious, if they have a visual impairment, if they have partial paralysis, if they have seizures or spasms, if they are sedated, drowsy from strong painkillers or are recovering from anaesthetic, if they are delirious or confused, if they're affected by drugs or street drugs or alcohol, if they're on a pressure relieving mattress which gives at the side, if they use bed rails at home, if they've self-operating profiling beds. So the next question is: how likely is it that the patient could be injured in a fall from bed? Injury from falls from bed may be more likely and more serious for some patients than others. For example, if they have osteoporosis, if they are on anticoagulants, if they're older, if they have fragile skin, if they have a vascular disease, if they're critically ill, if they have long-term health problems, if they are malnourished. And then, will not using the bed rails cause the patient anxiety? Some patients may be afraid of falling out of bed even though their actual risk is low. So if that is the case, we can put in a score there of 1, okay? So the total score, and we put in our initial. So bed rail use is recommended if the score above is greater than on the score on the right. So we'll go through the red side now. So the risk of using bed rails, we put in our date. Would the bed rails stop the patient from being independent? So bed rails can be a barrier to independence for patients who otherwise could leave their bed safely without help, okay? So we shouldn't be using bed rails for those kind of patients. We might have a patient who is confused or who is likely to wander, but we cannot, but they can get out of bed safely. We cannot pull up the bed rails to try and prevent a patient from wandering, okay? So if that's the case, we put in a score of 1. Is the patient likely to climb over the bed rails? So an injury severity can be increased if the patient climbs over a bed rail and falls from a greater height. It is patients who are significantly confused and have enough strength and mobility to clamber over bed rails that are most vulnerable. Okay, so if you think that's an issue, you put in your score of 1. Could the patient injure themselves on the bed rails? Bed rails can cause injury if the patient knocks themselves on them or traps their legs or arms between them. The most vulnerable patients are those with uncontrollable limb movements, who are restless and significantly confused, or with fragile skin. Bed rails, even when correctly fitted, carry a very rare risk of postural asphyxiation. Patients who are very confused, frail and restless, is this patient likely to be at risk? And will using bed rails cause the patient distress? So some patients don't like bed rails and may feel distressed or trapped by them. So we can put in a score there. And we get our total score. Bed rail use is not recommended if the score above is greater than the score on the left, okay? So remember that this is just a guide to help you decide whether you are going to use bed rails. Bed rail use is recommended if the score above is greater than the score on the right. So if you are using bed rails, document the use of bed rails in Care Plan 1A, B or C on page 6 and complete the restraint, release and review chart at the patient's bedside. This is the restraint, release and review chart. This is available on the wards and it is kept at the patient's bedside for any patient who is where there's a restraint being used, including bed rails. So you put in the details here, okay, and restraint to be removed every 2 hours for 10 minutes when awake and while visitors are present, unless documented to the contrary, okay? So you need to, it's sectioned off here from 8 to 10, 10 to 12, sectioned off every 2 hours. So you just initial to say that you have released the restraint every 2 hours for 10 minutes when the patient is awake and while visitors are present, unless documented to the contrary, okay? So that's a form that is used for all restraints, and if we're using bed rails, we need to complete this form. If we are using bed rails, it needs to be documented within the patient's care plan also. Here is the last intervention: bed rail risk balance tool completed, bed rails in use, restraint, release and review chart documented while patient awake. So we initial and date there if we are using bed rails. Please note that the bed rail risk assessment tool does not need to be completed for patients who are on a trolley, are being transferred in between departments, or are in the immediate post-anaesthetic phase. In those cases, we have to use bed rails. We don't need to do the risk balance assessment for those patients. Going back to our maintaining a safe environment assessment, we look at any other risk factors that impact the safe environment. Has the patient been identified as a vulnerable person? If so, we tick there. Is there any concerns of neglect or abuse? Yes or no? And if so, report and document concerns. Liaise with the multidisciplinary team and appropriate authorities. Is there any medication that might impact the patient's safe environment? Have they any invasive devices? The potential for or impaired consciousness, or anything else that might impact on the patient's safe environment, okay? So if there is, we can activate this Care Plan 1D, other risk factors present, and if there is nothing here in the pre-printed interventions, you can write in your own interventions there. So the next, the other part of this care plan is Care Plan 1A, the potential for patient well-being or safety to be compromised. So the expected outcome is the patient feels safe, secure and part of a caring environment. You will notice that all these interventions are highlighted in yellow and the boxes here are all merged. That's because all these interventions are relevant for all patients in Portiuncula Hospital. So we would be activating all these interventions, and here one initial and one signature will suffice. Okay, so ensure ID band is in situ, orientate patient to the ward area, demonstrate use of call bell and place call bell and belongings within easy reach, discuss plan of care including discharge plan with patient, ensure all physical, spiritual, psychological needs are addressed, clarify any concerns daily, where patient is able to respond, ask the patient how she or he is feeling and document, place bed in low position with brakes locked, keep area free from clutter and easily navigated, and advised of visiting hours. So we'll just scroll down to the next part of maintaining a safe environment. That's your falls assessment tool there, but just underneath that is an assessment: is the patient for surgery or procedure? So yes or no. So they may not be for a surgery or procedure on admission, but maybe during the patient's stay you might need to come back here and document, and you can write the details of the surgery or procedure here, and you can activate care plan money. Patient is for surgery or procedure. The expected outcome is safe preparation of the patient for surgery. So the interventions here are very generic: allow patient to express worries and anxieties, monitor and record vital signs, provide pre and post operative education, provide education and booklets where applicable, specific pre-operative preparations are completed and document, complete pre-operative checklist, patient has been fasting for recommended time, provide oral care, and anti-embolic stockings applied. And then there's blank ones if you want to put in some more specific interventions. And then post-op instructions. So if there's specific interventions for post-op, we can document them there and activate here. And we'll scroll down page 8. So at the bottom, this is the 4AT assessment, which we've done already, but at the bottom of this page, we have the pain assessment in advanced dementia scale, okay? So this is a pain assessment for patients who are non-verbal or have advanced dementia. We look at different elements of the patient's behaviour and we score accordingly to help us assess if the patient is in pain or what level of pain that they are in. So we look at the patient's breathing independent of vocalization first. So if that is normal, then we score 0. If they have occasional laboured breathing or a short period of hyperventilation, we score 1. And if they have noisy laboured breathing, long period of hyperventilation or Cheyne-Stokes respirations, a score of 2, and we put our score in there. If there is negative vocalization, if there's none, a score of 0. If there's an occasional moan or groan or low-level speech with a negative or disapproving quality, a score of 1. If the patient is calling out a lot, loud moaning or groaning or crying, a score of 2. We look at the patient's facial expression. If they're smiling or inexpressive, a score of 0. If they appear sad, frightened, or if they have a frown, a score of 1. Or if they have facial grimacing, a score of 2. Their body language, if they appear relaxed, a score of 0. If they appear tense, distressed, pacing, if they're fidgeting, a score of 1. And if they are rigid, fist clenched, knees pulled up, pulling or pushing away or striking out, we document a score of 2. And consolability, if there's no need to console, a score of 0. If they're distracted or reassured by voice or touch, a score of 1. But if we're unable to console, distract or reassure, then a score of 2. So we add up our score to get our baseline total score. If the patient is scoring from 1 to 3, that would indicate mild pain, 4 to 6 moderate pain, and 7 to 10 severe pain. So if you're using this assessment tool, you'll activate care plan 2B. So that's going into our next section on page 10. And that's going into ADL communication and pain, and record subsequent scores in daily evaluation.